This is Don Sharp with OBR, and I'm here today with Dr. Figlin. Dr. Figlin is the Steven Spielberg Family Chair in Hematology Oncology at Cedars-Sinai Medical Center. Dr. Figlin, thanks for taking a little bit of time with us today.
Happy to join.
We noticed that recently you commented on an article having to do with value in oncology, and I wanted to follow up on that and see if I could capture some more of your perspective on it. Based on the comment that you made in OBR, it sounds as though you're concerned that clinical advances we're seeing today may not actually make it to the patients due to the economics of the industry. Is that true?
Well, I think the key for oncology is to match clinical outcomes for patients, supporting them in their disease, while also being attentive to what I would otherwise call the value discussion, which is to make sure there's a balance between the cost of delivering care and the outcomes that are received. And I think that we're expecting that over the next years, as we develop new therapies in cancer, as these therapies hit the marketplace, that as oncologists, we're going to want to bring them to our patients. But at the same time, we have providers, institutions, payers, and an industry which are not always aligned with respect to how to get that to the patient. And I think the value conversation is really, of the options available for a given individual, cost has to become part of the conversation.
You're encouraging oncologists to discuss cost with patients.
Not only to discuss cost with patients, but also to understand the cost structures of how care is delivered, because what I would like to see is I'd like to see the oncologist at the helm of making those decisions, as opposed to the payor telling the oncologist what to do. We are in the best position to advocate for our patients. We're in the best position to advocate for the proper therapy. We're in the best position to understand how to integrate the literature across multiple years of therapies, and then how to understand the comorbidities of the individual and the care that we need to deliver. That's not easily done by just looking at records or looking at a piece of paper describing a person's illness. It is best done, in my view, by a person at the point caring for a patient. And as oncologists, my view is clear, and that is that if it's not for us, who will it be? We are all trained to deliver care. Give us the tools to not only deliver the care, but to have in the conversation the value discussion.
Mm-hmm. Now, coming back to the therapeutics that you sort of have to make these decisions on, I think a potential solution, in your opinion, was to somehow incentivize the industry to develop novel agents. Do you have any further thoughts on that?
Well, I think that historically what we've done is we've developed therapeutics using a therapeutic index which is outcome-based. And I understand that, and certainly over the 30 years that I've been practicing, we've come a long way to developing novel and new therapies. It is also clear that sometimes therapies with comparable outcomes cost different, whether it's given orally or intravenously, in the hospital, out of the hospital. And the physician has to have that in their conversation. And I think that the algorithms that we're going to be asked to do and deliver care under have to be algorithms that are not just outcome-based, but also cost and outcome-based.
And you think that, do you think that the regulatory bodies, right, the FDA, could participate in this analysis so that drugs that are approved and then reimbursed are captured by the regulatory industry in some way, so that you know that you're getting a valuable therapeutic when it comes available to you?
Yeah, so I don't know that we in the United States are prepared to invest in the FDA having that decision-making approach. I mean, the FDA does a very good job at determining efficacy and safety in balance. Mm-hmm. And I think it's going to be up to a different organizational structure, whether it's at the institution or a NICE-like structure that they have outside of the United States, that is going to be able to integrate the value conversation. And I don't know that we need to put so much of that on the FDA. Let them stay at what they're good at doing. But let's all of us have conversations around, okay, if the FDA has approved drug X, how do we integrate drug X into an existing paradigm balanced by the outcomes, benefits, and cost of the care delivered?
Yeah. Well, thank you, Dr. Figlin, for your provocative thoughts on the value conversation taking place, especially post-ASCO, where we saw novel therapeutics introduced and presented, and the discussion goes on about what the healthcare system can sustain with those.
I mean, I think that, and thank you, Don. I think that all of us in oncology want better drugs, more effective treatment, and better outcomes for our patients. Having said that, we're also sensitive to the fact that our R&D efforts in this country are extraordinary, and we don't want to hamper them to get what they need out of the process while we're having to deliver care in a model that's a little different than we've developed and given over the last decades.
Right. Thanks, Dr. Figlin. Take care.
Nice talking to you.
Okay.